A warm greetings to everyone. I am Chiranthan HR, a second year MBBS student from KRIMS, KARWAR. Today, I will be presenting my seminar on the topic Poststreptococcal glomerulonephritis, or to keep it in short, let's say it as PSGN. PSGN is an important cause of acute nephritic syndrome and also a classic example of immune-mediated renal diseases. Before moving into the topic, I'll briefly outline the objectives of this presentation. The objectives of this presentation are to define poststreptococcal glomerulonephritis or PSGN and understand its clinical importance, to identify the etiological factors and nephrogenic streptococcal strains responsible for PSGN, to explain the immunopathogenesis of PSGN with special emphasis on type 3 hypersensitivity reaction, which forms the core mechanism of this disease, to describe the pathological features of PSGN, including gross and microscopic findings, to discuss the clinical manifestations and laboratory investigations used in the diagnosis of PSGN, and finally, to outline the principles of management and treatment of poststreptococcal glomerulonephritis. With these objectives in mind, let us begin by placing PSGN in the broader context of the kidney diseases. The kidneys can be affected by a wide range of disorders such as renal failure, congenital malformations, glomerular diseases, tubular and tubulointerstitial diseases, obstructive uropathies, renal vascular diseases, tumors, and lower urinary tract infection. Among all these conditions, diseases affecting the glomerulus are particularly important because they directly interfere with the blood filtration process. Now let's look what are these glomerular diseases. Glomerular diseases are disorders that affect the glomerulus, which are the functional filtration unit of the kidney. Damage to the glomerulus leads to abnormal filtration resulting in proteinuria, hematuria, and reduced glomerular filtration rate. These abnormalities form the basis of the most renal clinical syndromes. Glomerular diseases can be classified in three important ways. That is, based on the clinical syndrome, can be classified as nephritic syndrome and the nephrotic syndrome. Based on their etiology, they can be classified as primary glomerular diseases and secondary glomerular diseases. Based on the duration of onset, they can be classified as acute, chronic, and rapidly progressive glomerular diseases. Poststreptococcal glomerulonephritis typically presents as an acute nephritic syndrome. Now let's look about what are the clinical manifestations of a glomerular disease. The common clinical manifestations of glomerular diseases include proteinuria, hematuria, hypertension, and disturbance of excretory function. These features indicate damage to the glomerular filtration barrier. Glomerulonephritis is defined as inflammation of the glomeruli, leading to impaired filtration of blood. Glomerulonephritis can be classified based on onset as acute, rapidly progressive, or chronic, and on the basis of the etiology, it can be classified as primary glomerulonephritis or secondary glomerulonephritis. Poststreptococcal glomerulonephritis is an acute immune-mediated glomerulonephritis. Now let's look on the pathogenesis of the glomerulonephritis. The pathogenesis begins with the formation of the immune complexes. These complexes get deposited in the glomeruli, leading to inflammation and glomerular damage. This results in increased permeability, progressive scarring, and in severe cases it may lead to chronic kidney disease or renal failure. Now let's look at what are the important clinical features of the glomerulonephritis. The key clinical features include hematuria, proteinuria, edema, hypertension, oliguria, and systemic symptoms such as fever. These features together constitute the nephritic syndrome. Now let's move on to the topic of discussion, poststreptococcal glomerulonephritis. It is an immune-mediated renal disease occurring 1 to 3 weeks after a streptococcal infection. The infection is usually pharyngitis or impetigo caused by nephrogenic strains of group A beta hemolytic streptococci. Importantly, renal damage occurs after the infection has subsided. Now, let's look at the etiology of the PSGN. The major streptococcal antigens involved here are streptococcal pyogenic exotoxin B and nephritis associated plasmin receptor, or let's call it in short as NAPLR. Nephritogen strains include types 12, 4, 1 and red lake strains of the streptococcal bacteria. At this stage, an important question arises. If the streptococcal infection has already resolved, why does kidney damage appears week later? The answer lies not in the bacteria itself, but in the immune response of the host. PSGN is not caused by direct bacterial invasion but by immune complex deposition. This leads us to the immunological basis of PSGN, that is the type 3 hypersensitivity reaction. Type 3 hypersensitivity is an immune complex mediated reaction caused by deposition of antigen antibody complexes in tissues. These complexes activate complement and cause inflammation. This reaction is not tissue specific. Examples of such reactions are systemic lupus erythematosus, or call it in short SLE, serum sickness, and the PSGN. Now let's look what are these antigen components are. The antigen components may be exogenous or endogenous. Exogenous antigens are bacterial proteins, viral antigens, parasitic antigens, serum proteins, or even the drugs. The endogenous antigens include nuclear antigens, IgG antibodies, and the tumor antigens. Now let's move on and look at what are the features of type 3 hypersensitivity reaction. The antigens are soluble and form a circulating immune complexes which gets deposited in blood vessel walls, which leads to vasculitis, or in the kidney, which leads to glomerulonephritis, or it may even deposit in the joints causing arthritis. In these reactions, the antibody component is the IgG or the IgM antibodies. This reaction takes place by the process of complement activation and occurs within the hours to days of infection. Now let's look at the mechanism of the reaction. Antigens enters the circulations and antibodies bind to it and forms the immune complexes. These complexes get deposited in the tissues such as blood vessel walls, kidneys, joints, and even the skin. This leads to complement activation, that is C3A and the C5A. This is followed by the recruitment of neutrophils, which releases the lysosomal enzymes that cause tissue damage and inflammation. Now let's understand the mechanism by studying it in a diagram. The first step is the deposition of immune complexes, which means the deposition of the antibody and antigen complex, which leads to complement activation, that is C3A and the C5A. This brings the neutrophils to the basement membrane, which through the mechanism of ROS generation leads release of inflammatory mediators and lytic enzymes that damages the tissues. Now, in further slides, we will discuss about the pathogenesis of PSGN. There is a history of streptococcal infection 2 to 3 weeks earlier before the onset of GN. A latent period is allowed for the antibody formation. Laboratory evidences include elevated ASO, that is anti-streptolysin O, and anti-DNase B. The complement level shows decreased C3 with normal C4 levels. The decreased C3 levels returns to normal in 6 to 8 weeks after the infection. Now let's look about the gross features of the person affected by PSGN. The kidneys are symmetrically enlarged and the weight is increased 1.5 to 2 times of the normal kidney weight. The surface shows tracheal hemorrhages producing the classic flea-beaten kidney appearance, as you can see in the diagram. Now let's look what it looks under the tight microscope. The glomeruli shows diffuse hypercellularity due to proliferation of mesangial and endothelial cells, which you can clearly see in this diagram. There is a leukocyte infiltration that produce an acute exudative lesions. The tubules of the kidney show RBC and WBC casts, while interstitium shows edema and inflammation. Now let's concentrate about what are the clinical features of post-streptococcal glomerulonephritis infection. The patient presents with a history of 2 to 3 weeks of throat infection, a history of 3 to 6 weeks of skin infection. Along with it, he complains about hematuria, oliguria, edema, and hypertension. Systemic symptoms include fever, headache, nausea, and vomiting. In severe cases, he may develop acute kidney injury or right heart failure. Now let's look about what are the laboratory investigations to be performed. They are urine analysis, blood investigation, specifically renal function test and the complement levels, and evidence of recent streptococcal infection, serological and inflammatory markers, and immunological tests. In urine analysis, it shows hematuria and proteinuria. Blood investigations reveal raised renal parameters and low complement levels. Serological tests confirm recent streptococcal infection. Now in the last part, let's look about the treatment options. The treatment is generally managed by supportive measures. Bed rest and monitoring of blood pressure, urine output, and renal function are essential. Dietary management includes salt and fluid restriction to control the edema. Loop diuretics like furosemide are commonly used to control the edema. To control hypertension, diuretics, calcium channel blockers, and ACE inhibitors are given. Penicillin is used to eradicate streptococcal infection. In severe cases, requires dialysis and supportive care. Now as we come to the conclusion part, to conclude, poststreptococcal glomerulonephritis is a classic immune-mediated renal disease following streptococcal infection. Early diagnosis and appropriate supportive management usually results in an excellent prognosis, especially in children. As we come to the last part, to conclude, poststreptococcal glomerulonephritis is a classic immune-mediated renal disease following streptococcal infection. Early diagnosis and appropriate supportive management usually result in an excellent prognosis, especially in children. Thank you for your patient listening.